Okay, everyone. As promised in class this morning, I just want to cover these last few slides here regarding pediatric respiratory problems. Um, the last disorder of the lower respiratory tract that I wanted to discuss with you was that of cystic fibrosis. We mentioned this disorder briefly at the end of our last semester when we were talking about genetic disorders, because again, it is an autosomal recessive multi-system disease. So yes, it does affect many different systems of the body. And although it is multi-system, the most important effects of cystic fibrosis are indeed on the lungs. And that's why we're covering it here when talking about disorders of the lower respiratory tract. So yes, important effects on the lungs, and respiratory failure is almost always the cause of death because of this disorder. It is characterized by, as you see here on the screen, either exocrine or mucus-producing glands that secrete an abnormally thick mucus from them. And the reason this happens is because of a defective epithelial ion transport, and that is the genetic defect. So the genetic defect actually causes this defective epithelial ion transport. And so what happens is that this cystic fibrosis mucus is extremely dehydrated and viscous because of defective chloride secretion and excessive sodium absorption. So the defects in chloride and sodium are what cause this very dehydrated and thick mucus in cystic fibrosis. And so that can affect many different organs. It causes this sort of backup of proper flow because of this abnormal mucus in a lot of organs. And in the lungs specifically, it's these thick secretions that obstruct the bronchioles and certainly predispose the person with cystic fibrosis to chronic infections. It's because anytime you have excessive secretion sitting around, those secretions are certainly at risk of becoming infected. So you see in this disorder chronic inflammation. And not only do you see this inflammation and this thick mucus, but it's that inflammation that leads to actual changes in the cells. So it leads to hyperplasia of the goblet cells, which, as we know, are the cells that actually secrete mucus. You see bronchiectasis, you can see pneumonia, obviously hypoxia because of oxygen trying to and being unable to move through these thick secretions to be diffused into the blood. And then after a long chronic sort of exposure of the tissues to these problems, you'll see fibrosis and scarring. So when we're talking about clinical manifestations, especially sort of acutely in the short term, we're seeing things like persistent cough. You'll hear wheezing upon auscultation. Again, these people are certainly at risk and sort of more predisposed to recurrent severe infections like pneumonia. And then, as you move to sort of more chronic physical signs that develop over time of someone with cystic fibrosis, you're basically looking at things that would sort of equal hypoxia, chronic long-term hypoxia. So you can see things like polycythemia. You'll see, again, that's because of the body trying to compensate for this chronic hypoxic state. You'll also see clubbing, that abnormal change to the shape of the nail beds that we talked about last semester. And you also may see some barrel chest going on in these people, again, because these thick secretions sort of trap and make exhale of gas difficult, and so it overinflates the alveoli, and you can see barrel chest in these patients as well. Again, the major sort of problem is the damage that it does to the lungs, and you will eventually see respiratory failure occur in patients with cystic fibrosis. That being said, the projected life expectancy of someone with cystic fibrosis is indeed much shorter than normal. The projected life expectancy has increased over the last decade or so, but it still has just increased from about 31 years of age to only about 37 years of age. So again, life expectancy is still drastically shortened in someone with cystic fibrosis because of multi-system, but specifically respiratory factors. Again, there is testing for this specific genetic disorder. You can do genetic testing sort of ahead of time of the parents, genetic testing of the baby itself. And there's also a more physical test called the sweat test, which actually reveals excess sweat chloride concentration. They actually look at someone's sweat. And so that can actually help diagnose and make a clear diagnosis of cystic fibrosis. Treatment is primarily focused on nutrition and pulmonary health. You will also see breathing treatments be especially helpful in someone with cystic fibrosis. Again, anything to sort of decrease inflammation and open up and bronchodilate those airways. And chest physical therapy is also very helpful in getting some of that excessive mucus and excessive thick secretions up and out of the airway of people with cystic fibrosis. So those vibrating vests, that chest PT that we talked about earlier today, is certainly a key sort of point in treatment for cystic fibrosis. But again, cystic fibrosis is a disorder that significantly decreases life expectancy because of inadequate airway movement. Okay, so that's cystic fibrosis for you. And then here again, as I mentioned throughout the morning today, is just kind of a visualization or a pathway for you, if that's helpful. Okay, and then last but not least, wanted to just quickly discuss sudden infant death syndrome. SIDS is certainly defined as the sudden, unexpected death of any infant or young child in whom a post-mortem examination fails to demonstrate a cause for death. So upon autopsy, there is no reason, there is no explanation, there was no underlying health concern, there was no respiratory infection, there was nothing found upon autopsy. And that is how you define sudden infant death syndrome. To be sure, it is certainly a phenomenon in young infants that is not completely understood. As you see here on the screen, the incidence sort of increases in the second month and peaks at about 3 to 4 months of life. So you really don't see it very early on, like in the first month or so of life. And also, clearly, the risk decreases significantly between the months of 6 and 12 months of age. Again, not completely understood, not completely explained, but it is more commonly seen in male infants. There seems to be some theories that looks like there's some sort of seasonal variation on the rates that you see, so that being that there's a higher incidence in winter. This could be because of possible relationship to increased risk of respiratory infections during the winter months. It also could be because of the use of heaters or fireplaces during the winter months. If you look down there at the bottom of the screen on this slide, you'll see that there's some risk factors that look like there's can be some environmental factors like smoking in the house or overheating of the baby itself. So perhaps that's to explain why there's a possible relationship to winter. Again, the etiology is not completely unknown. The leading hypothesis right now at this time is that there is some type of developmental immaturity, just basically immaturity of the baby to really know how to breathe, of ventilation. So there's some immaturity of the breathing mechanism of a baby and also some immaturity of their arousal responses to some type of hypoxemia or hypercapnic stimulation. So that is to say that if we sort of had our nose and mouth covered, we would sort of, our system is mature enough to know to move our head, to change our position, to do something while we're sleeping to counteract any hypoxemic or hypercapnic stimuli. But babies are sort of developmentally immature. They can't roll over. They can't, maybe don't have proper neck controls for them to lift their head and reposition their head during sleep. And so this looks like it may be a leading hypothesis for reasons for why this just sort of sudden death occurs during an infant's sleep. Other wide range of risk factors could be a low birth weight, prone sleeping, so lying face down is not recommended. That's why there's always this big educational campaign of putting babies on their back for sleep so that any sort of smothering kind of risk factors are decreased. That's, so that they're not face down in the mattress, especially if they're too small to roll over or too small to lift their head up, that we're not having any sort of smothering kind of effect. And so that being said too, too soft of sleeping surfaces can be a risk factor. That's also something that they really educate mothers on upon going home postpartum is no blankets, no pillows, no stuffed animals in the crib. A crib mattress should be extremely firm so that there's no risk of sort of smothering or getting a baby's face sort of too deep into some sort of soft fabric or soft pillow or something like that and basically causing a smothering effect. So again, extremely tragic that these babies, there's absolutely nothing wrong with them pathophysiologically. They were born, full term, totally normal, healthy babies, and something happens while they're sleeping because of their developmental immaturity that they just don't respond appropriately and accurately enough to some sort of hypoxic or hypercapnic state while sleeping, and they just die. It's very, very devastating. So it's really important to do a lot of good education, again, postpartum with mothers and babies who are being discharged from the hospital to sort of decrease this risk. And again, the reason I sort of include this in the respiratory pulmonary content is because they really do feel like there's a strong link between sudden infant death syndrome and some type of decreased arousal to hypoxemia and hypercapnia. All right, thanks guys. We'll start Thursday with renal.